Hello, everyone, and welcome. Welcome to our conversation in our virtual Regional Policy Council meeting, where we are talking about psychedelics. I'm Debbie Plotnick. I am the Executive Vice President for State and Federal Advocacy at Mental Health America. And I am so pleased you are here with us today. I have a couple of really important housekeeping announcements. The first thing I'd like to do is to thank our sponsors. So please help me thank Alkermes, Janssen, Myriad, Neurocrine, Utska, Synovian, Takeda Lundbeck, and Teva. Thank you so very much for the support of the Regional Policy Council. We're on a very tight time schedule today, so I'm going to ask you if you have questions for our speakers. As we go along, there's a Q&A button at the bottom of your screen. Please feel free to type them in there. Some of them they'll answer as we go along. And then the last 10 minutes of this 90-minute program, we'll have our speakers joining us live to be able to answer your questions. I am so pleased today that we're going to open this discussion with a recorded presentation from Dr. Saundra Jain and Dr. Rakesh Jain, and their bios are going to be in the chat so you can learn more about them. And we are ready to hear from the doctors. Jan.
Hello, everyone, and welcome to this presentation. My name is Rakesh Jain, and I will be teaming up with Saundra Jain, who is my work partner and also my partner in life. And we're going to talk about a topic of great interest, not just to us, but I think to society at large, which is, are we ready for psychedelic therapy? And we will offer you an examination of the potential advantages and pitfalls of psychedelics. I will cover section 1, and I, by the way, am a psychiatrist, and Saundra will come in just a minute or two, and Dr. Saundra Jain is a psychotherapist. Now let's talk about section 1. Let me offer you a quick introduction to what are psychedelics. And right now, there are really 3 windows people are taking to better understand psychedelics, and clinicians are either supportive of it, or opposed to it, or curious about it. There are 3 distinct camps. And if you think about the public at large, they also fall into these 3 camps. And what we're going to advise you to do is please don't be either a supporter or opposer. It's probably better to be curious and then decide for yourself which way you wish to go. And right now, what we are seeing from the public at large is they're coming to us both in formal and informal conversations, and they're bringing with them lots of questions. And Saundra and I will do our very best to address them so that you are prepared for what is going to be a pretty impressive renaissance in psychedelic medicine. And the approach we recommend you take is curiosity. Don't pass judgment yet. Be curious, not judgmental. That's what Walt Whitman said, and I think that is indeed the very best approach to take. Let's listen, let's learn, let's grow. But let's do it in a fair, balanced way. There's a lot of fluff in the field of psychedelic medicine. There's a lot of truth in the world of psychedelic medicine. Your and my job is to parse through it so we get to the truth. And please remember that in America and in the world, we've tried prohibition a number of times. Well, that did not work out too well. And here's a great quote: for every prohibition one creates, we also end up creating an underground. That's why today's conversation about better understanding psychedelics and the strengths and weaknesses of psychedelics is just so important. First of all, the need for looking at mental challenges differently is actually great. Here are just 3 quotes. These are real quotes from real people. This is someone who is a war veteran who's talking about his suffering because of PTSD and depression, so many years of no treatment. Person is reporting depression, anxiety, PTSD, 10 years, waiting for something to work and not finding that the traditional medications are doing the trick. So we clinicians are looking for new ways of helping individuals who aren't helped by traditional therapies. By the same token, the public out there, in many ways, is finding that our traditional psychiatric treatments don't always address the needs. As a result, psychedelic medicine has become of great interest. And you might be wondering, are people actually using psychedelics already? We don't have any legalized ones. And here's the truth. More than 30 million Americans, 17% of us, adults, have already had psychedelic experiences. Not in a research setting. In fact, only 0.001% of the 30-some million people actually have had their psychedelic experiences in a research setting. So what are the rest of the people doing? Well, they're using it on their own. They're using it perhaps overseas. But the truth of the matter is, if they're using it, there must be a reason why they're using it, right? Curiosity demands that I look into it a little bit. So caution is the rule. Now, caution doesn't mean opposition. It doesn't mean full embrace. Caution only means caution. That is the rule. The best way to get ready for the psychedelic medicine revolution is to have these conversations like you and I and Dr. Saundra Jain will have in a minute, and to be prepared. So just a couple of years ago, Saundra and I started what is now the world's largest survey of better understanding why do people use psychedelics in terms of wellness enhancement. So us and a few other colleagues got together. It is now a publication. We will tell you a little bit about it, and you're welcome to access it for yourself. The reference is given at the bottom. You will get this whole article for yourself. This study is called the PAUSE study, Psychedelics and Wellness Study. It has been published in the Frontiers of Psychiatry. And we were very interested in seeing when people use psychedelics, what exactly is better? Why are they attracted to it? So we measured mood, anxiety, wellness. We looked at all of that. But we also were careful to look at what happened that was negative. How did this actually harm them? And we're now at over 3,000 respondents to it. In this particular publication, we had 2,500 plus people who were kind enough to give us their data. So what did we see? Why are people using psychedelics? What we found is they're doing it because it reduces depression for them, it reduces anxiety for them, and it improves wellness. Your question might be, how much? Well, I just put something in a red box on the right-hand side. That's called the Cohen's d effect. Anything that is 0.8 or greater is considered a large effect. What people are reporting, spontaneously reporting really, is that on mood and on anxiety and on wellness, they are getting benefits from psychedelics, and they are large benefits. Also, they're reporting, I've got another red box here for you, that they don't have to keep using it. It's not hundreds of use. Apparently, a lot of the benefit that they get in terms of improvement in wellness appears to max out at between 5 to 10 doses. And for depression and anxiety, it seems to max out at 15 to 20 doses. But the take-home message is people are using psychedelics already in America. They are, for the most part, using it apparently not just to have fun. It doesn't appear to be just a party experience, though it can be that too. There's also evidence, as I'm showing you on the screen, that people are using psychedelics because it reduces their depression, anxiety, and perhaps improves their wellness. We do want to report to you that our research showed about 13%, which is not a very small number, actually reported some harm. Occasionally, they led to increase in benzodiazepine use or cannabis misuse or cigarette use. Occasionally, very rarely actually, to aggression, to criminality, to desire to die by death. But the majority of people got the opposite benefit. They actually reported a reduction in a desire to die by death, reduction in criminal impulses. The take-home message is, while the majority of people are reporting benefits from psychedelic use, there is the presence of a small number of people who are actually harmed. That's why this conversation is important. We should not take the approach of psychedelics are good for everybody or psychedelics are bad for everybody. It's more nuanced. It appears they are, on the whole, better for most, but they can be harmful for some, and our goal is to obviously reduce down to zero, if possible, the harm psychedelics can bring. So let me transition for a second, because psychedelics are not just one medication. They come in a very large class. It's quite likely you're familiar with MDMA and LSD, but there are actually a whole lot others. Ayahuasca, for example, DMT, 5-MeO-DMT, and a bunch of designer drugs are on their way, if not already here. And how do psychedelics actually work in the brain? Different mechanisms, but what are called the classic psychedelics, that would be magic mushrooms. So psilocybin or LSD or DMT, ayahuasca. Main ingredient, of course, is DMT. What they do is they actually stimulate one of the brain receptors called the serotonin 2A receptor. And you might be going, so who cares about that? Well, this is the wonderful thing. By stimulating it, the brain's network connectivity is vastly enhanced, which then reduces this continuous chatter we have in the head of don't do this, don't think that, or think this, whether you want to or not. That constant cortical or brain chatter over our emotional life is reduced, which then leads to a freeing of the mind, so to speak. Reorganization with new patterns, alleviation of symptoms, and neuroplasticity. None of these are hypothetical. These have now actually shown to be the case with psychedelics. So let me see if I can illustrate that for you. So in depression, there is top-down control, there's bottom-up information. So here we have a person having a wonderful time with friends. But if this person is depressed, pretty much what they get is, yeah, you may have had a good time, but they're going to leave you if they really got to know you. That chatter, that negative chatter, which doesn't allow us to fully experience positive things that are happening in our life, dominates. Now, what if this person is on psychedelics or after the psychedelics are already gone from this system? What ends up happening is the top-down inhibition goes offline. So new information that comes in, that could be emotion, that could be sound, actually changes. The person can actually go, maybe I am lovable. It can move to, I believe I'm lovable. It can then move to, I am lovable. It can become a belief that the person has. Psychedelics can change rigid thinking into a more flexible, more positive way that a person can live their life by believing in these new formed ways of thinking about particularly negative situations. And humans have been using consciousness altering substances for a long time, sometimes with sound, sometimes by ecstatic dance. But usually we humans have been changing our own consciousness with plants and fungi. And I'm showing you a world map where the evidence is for hundreds, sometimes thousands of years, we humans have self-discovered if we eat certain plants or eat certain fungi, our mind is changed, our consciousness is changed, which often leads to positive effects. So now I'm going to do a kind of a deep dive into a couple of substances that we now use for psychedelics. And here's ketamine. And this one does not come from a plant source or a fungus source. This very much comes from a laboratory, ketamine. Ketamine is a psychedelic. The way to look at ketamine is it can be a psychedelic, it can be a medicine, it can be an anesthetic, it can be all of the above. But there's no question about it. When used in the right context, in a legal fashion, that's the key here. If you're interested in exploring psychedelic medicine because you want to, you need to, guess what? There's a legal mechanism available, which is ketamine. And IV ketamine, intravenous ketamine, intramuscular ketamine, but in particular IV ketamine, is already a therapy for depression as well as treatment-resistant depression. Here I'm just showing you a data set that strongly supports that ketamine, either through its work as a medicine or its work through a psychedelic or its work through both of them, actually is rather effective treatment for depression, even the difficult to treat depression. And how interesting, ketamine has now been repeatedly demonstrated to have a strong, specific anti-suicide effect. Now you see, don't you, why this whole arrival of psychedelic medicine for society and for us in the clinical world is such a positive development. So yes, ketamine is legal. It's not plant-derived. It's not fungus-derived. But it clearly, in the right hands, does function as a psychedelic. And Saundra, during her conversation with you, will offer you more information about where to get more information if you want to do a deeper dive into these sciences. Let's move on to talking about psilocybin. This one has been in the news a great deal since the Michael Pollan book, How to Change Your Mind, really became a runaway bestseller. And what is the evidence? Why are we so interested? It does appear psilocybin is also both a medicine and a psychedelic, but its psychedelic effects in this case really do predominate. They do. They're the dominant factor. Individuals who have a greater mystical experience of psilocybin tend to have the best short and long-term impact on depression. And Johns Hopkins, a well-known university, has been conducting a great deal of research proving that point beyond a shadow of a doubt. In fact, this study that comes from Imperial College in London shows that even in comparison to SSRIs, that would be, let me use some common names, Prozac, Zoloft, Celexa, Lexapro, that kind of medication. And in this case, the medication being compared was Lexapro, escitalopram. Here what we're seeing is psilocybin that was only used 2 times was as good as SSRIs in reducing depression, but actually better than SSRIs in improving wellness. Oh yes, I think we are onto something here. I think those of us who have a deeply curious mind look at such studies and go, I want to know more. Additionally, we now have evidence it's not just during the trip. That's the societal way of looking at a psychedelic experience. I think that is not a big enough term. These folks aren't just tripping, they're having actually a psychedelic experience. But nevertheless, even 6-month studies are showing that not everyone, but many people are actually reporting significant benefit from psychedelic therapy. It's almost as if their way of thinking has changed. The way of interacting with themselves has changed. The way of interacting with stress has changed. There's something profoundly interesting about the way psychedelics change many of us. And then MDMA. This used to be called, and still is called, ecstasy, though MDMA is, in these studies, used in a pharmaceutical grade, pharmaceutical purity chemical entity. And this is probably going to be our first FDA-approved psychedelic medication, which I expect would be in about 2 years or so. And the main reason for our great interest in MDMA is because of how effective it can be in helping people who are trapped by their history of trauma. And they're trapped because they cannot shake it off. They have rage episodes, they're in shock, they feel suicidal, they are depressed, they're anxious, they're jumpy, they're withdrawn. Now, not all PTSD comes from wars. It does come from there. But a lot of PTSD comes from family trauma, personal traumas. So, yes, there's great reason to believe that MDMA may be a very effective therapy combined with psychotherapy. That's why we call it MDMA psychotherapy and not just the medication itself. Okay? So MDMA facilitated psychotherapy. The data, and we have quite a bit now. We have multiple small studies and then large studies. that are exceedingly promising, not just in people with PTSD, but even those individuals who have PTSD that have failed traditional psychotherapies and traditional medications like SSRIs and other medications. In fact, the numbers of people who get short and long-term improvement with MDMA therapy is just so large that everyone has gotten very excited about it. And this is a phase 3 study. This is the final set of studies that a company has to do in order to get the FDA to approve the medication. And this is the first phase 3 study where the results were actually really impressive. They were impressive enough that most of us who work in psychiatry expect that the FDA will be giving approval to MDMA for the treatment of PTSD. So I just gave you a snippet of where we are, and I want, with your help, to look into the future of psychedelic research and practice. And I will perhaps end my part of the conversation with you where I started, which is curiosity. Please be extremely curious about both psychedelic medicine, psychedelic therapy, the strengths, which are very many, the weaknesses, and there are a few. We do not have to exaggerate either. We can put both of them into context. As you can see, and I just presented a little bit of the data on just 3 substances, ketamine, psilocybin, and MDMA. And there are, of course, many others. But as you just saw the results from these 3 substances, there is great promise to these medications, not just for the individual's healing, but an individual who's healed ends up helping the family system. And the family system that's helped ends up helping the community and society. So I am actually very excited for the future of psychedelic medicine, and I intend to be a curious observer, a curious learner in this world. So with that, I'm going to stop my presentation, and Dr. Saundra Jain is going to take over from here. Thank you for listening to me.
Hello, everyone. I'm so glad to be with you today. We're going to spend the rest of our time together talking about psychedelic-assisted psychotherapy, integration, which is what happens after the psychedelic experience, and then throughout this last part of the presentation, I'm going to drop in some resources throughout, hoping that you will be super interested and check them out on your own time. All right, let's get started. You can see on this slide there are sort of these icons that describe different mental health challenges: depression, obsessive compulsive disorder, addictions, anxiety, eating disorder, several of them listed. And what I want you to realize is that psychedelic therapy, what we believe is that it targets these overly rigid ways of how we behave, how we think, and really how the brain communicates. Now, in the literature, you'll see this described as low entropy states. But all I want you to remember is this: for these different mental health challenges, it's almost like we become a bit rigid, a little bit like a rusted trap. The trap is just rusted shut. So we behave in the same way, we have the same thoughts, and our brain is not communicating in a way that allows for psychological flexibility. And this is where it gets very exciting. Psychedelics appear to work across the diagnostic categories we just talked about by actually disrupting that rigidity. And the way this is done, one way it's done, is through psychedelic-assisted psychotherapy, which again occurs after the psychedelic experience. We're going to dig into that in a moment, but think about it this way. So some of that rigidity, how we think, behave, and how our brain networks communicate, imagine a snow globe. And through the psychedelic experience and the integration afterwards, you just shake the snow globe. And as the snow settles to the bottom, this is what happens. We're now just more flexible in how we behave, how we're thinking, and actually how the brain communicates. So new learning is possible. There are positive brain changes, the neuroplasticity, as well as positive behavior changes. All right, let's talk about legal psychedelics. Ketamine, which Rakesh has already talked about, psychedelic tourism, and churches, to give you some idea of what's legal in the United States. So first option, you can join a clinical research trial. And the way you find out about these, here are your resources. You can go to any of these sites to learn more about what's happening and what's available. But the one that is I think the richest resource, clinicaltrials.gov, because any research that has been registered with this government site is listed on clinicaltrials.gov. But of course, Johns Hopkins Center for Psychedelic and Consciousness Research, NYU's Psychedelic and Research Program, European research hubs, there are Canadian research hubs, so there are a lot. Now, obviously, we want to look at the trailblazers and we want to give credit to those who came before us, and many of them are still in the space, but they really paved the way. As you look at these different organizations, know that they come from the world of academia, they come from the world of nonprofits as well as corporations. Psychedelic tourism. So think about it this way. As a practicing psychotherapist, a lot of times my patients ask me about these retreat centers, psychedelic retreat centers that are in other countries where that psychedelic that is being used is legal. Now, you may have friends, family members, neighbors who are struggling with mental health difficulties, or maybe they're just interested in personal enrichment and growth, and they're talking about psychedelic tourism. I want you to know, I think this is the best advice that we can give you. Tread lightly, proceed with caution, and here are the reasons why. We'll touch on these just briefly, but certainly during Q&A we can dig into this more. First and foremost, the potency and the purity of whatever natural substance is being used as part of that retreat center, not the same. You're not able to know the potency and the purity because it's not a clinical trial. There are certainly documented cases of sexual assault at not all certainly, but at some of these retreat centers. So we want to proceed with caution, particularly with regards to this one. Accessibility issues, right? It costs a lot to travel outside of the country. And the retreat centers, there's a lot of variability in cost, but it can range from $5,000, $6,000, $7,000, pushing and exceeding $20,000. We want to think about reciprocity and sustainability issues with these indigenous communities. So when we travel to a community that has been using a psychedelic plant-based substance for centuries as a rite of passage, as healing, as religious ceremony, we must be consciously aware of issues of reciprocity and sustainability. Now, this is an important one. If in the United States, as we know, all but ketamine are illegal, they're scheduled substances, but we give the thumbs up to the top 3 retreat centers based on our personal opinion. Our clients go to that retreat center and something bad happens, what's the legal liability? We still don't know, but we must think about that. The very last one, if you're considering this, do your research, my friends. Know the training, the credentials of those who are facilitating the process. Learn as much as you can. All right, there's also legal path as a church member. These 3 options are legal in the United States because the religious sacrament is a psychedelic, either peyote or ayahuasca. Still an option, and I want you to know, do a Google search and you will see just how many of these there are in the United States. Okay, first ever, the state of Oregon, first in the United States to pass Measure 109, which legalizes psychedelics, specifically psychedelic magic mushrooms, so psilocybin. This was passed in 2020, and I want you to know they got a 2-year window to develop the model, to really create how this is going to be rolled out. And in January, the first week of January 2023, people will be eligible to apply for licensure to create and open these centers in Oregon. And what's very exciting about this, because I do believe as we learn more, as this rolls out, these centers begin to operate, we'll learn what works, what doesn't work, and it will probably become the gold standard for other states. But what's very interesting, these are not centers just for medicalization, the treatment of mental health difficulties, but also for people who are just interested in personal enhancement. So this is very exciting, and there are other states that are in the process of submitting these types of measures to their legislature. Okay, psychedelic integration. Let's spend just a minute on this. You see the definition of integration, pretty straightforward. I think it came from the Webster Dictionary. But during a psychedelic experience, little bits and pieces will be revealed to people, learnings, messages, things they may see while in that non-ordinary state of consciousness. And the process of integration is taking those little bitty pieces of the puzzle and creating a whole. It's what we refer to as meaning making. Alan Watts, a British writer, author, and philosopher, this is a great quote because what he says is the drugs don't impart wisdom at all. They provide the raw materials. We take that information and then we integrate it into our everyday lives. Of course, I've paraphrased just a bit, so forgive me for doing that. This is a great book if you really want to learn more about psychedelic integration because it is the process of taking what we learn in psychedelic experiences and then deciding how we're going to translate that into our everyday lives and make positive changes, not only in our behavior, but how we think and how we integrate those learnings. We call it meaning making. I want to comment just the fact number one, that it is an ongoing process. It's really not you do it once and you're done. But that psychedelic integration, the work after the experience, really does take place over time. Harm reduction, let's just comment on this briefly because it is important. This is all about reducing negative consequences. So many of us come to this new space of psychedelic work, but we may have been raised and exposed to what happened in the 60s and 70s. And you'll see, oh, let's see, actually, let me go back because I do want to make just one comment about this. So you'll see, you'll remember things like just say no to drugs, abstinence. Remember that commercial with an egg frying, this is your brain on drugs. So this is a move away from that and more respect and understanding for those who are seeking healing and personal enrichment through the use of psychedelics. Great resources. I will not spend a lot of time talking about these other than to say, please research these on your own. Arrowhead, for example, is a database of natural psychedelics as well as synthetic psychedelics. It is the most comprehensive site, for example, drug-drug interaction, and just giving people the information and the knowledge they need about these medicines and substances. Zendo is a project that was created specifically for harm reduction. It developed and continues as an on-site service at Burning Man, dance festivals, music festivals, regional Burning Man across the United States, and they are there to hold space and sit with people who may be having a difficult experience in the process of a psychedelic journey. Fireside is exceptional. It is an app-based resource so that if a person is having a psychedelic experience and it's very difficult for that person, they can actually call in, speak to a trained volunteer who will help walk them through that, or they can call after the experience to do actual psychedelic integration. So it is absolutely great program. All right, couple of newsletters, well, actually one and then a couple of podcasts. More resources. The Johns Hopkins Center for Psychedelic and Consciousness Research, their newsletter, if this is something you want to learn more about and stay abreast of what's happening in this space, please go to this website and sign up for their newsletter. It is comprehensive and just current, quite remarkable. All right, podcast. Everybody loves podcasts in this day and age. So here are two. I have to say, most importantly, these are really fair balanced podcasts. Not that these are the only two that are fair balanced. You can access them the way you access all of your podcasts. But I absolutely love Psychedelics Today. They interview just a broad array of people, luminaries in the world of psychedelics, new and upcoming researchers. It's just quite remarkable. So don't forget, podcasts are a great way to learn about psychedelics. All right, let's just, before we jump into Q&A, live Q&A, let's just kind of summarize where we are. And this is it. You just got to hold tight. We are racing forward at a speed that it's just lightning speed. But we must step back, hold tight, because we want the research to guide our steps forward. And here's the great news. There are so many well-conducted, double-blind, phase 2 and phase 3 studies that are underway in the world of psychedelics across different disease states. So that it's going to be a rich supply of data and information to guide us forward. And those phase 3 studies, we're hoping that the data is going to be made public and available to us very soon, certainly in the first part of 2023. So again, I'll say, let's just hold tight. I know we're all chomping at the bits because we want to know what's ahead. We want to really be able to predict what this is going to look like in 3 to 5 years. As a practicing psychotherapist, the number of questions I receive from the people I work with about psychedelics, what's available, what does the data tell us, it's quite remarkable. 5 years ago, I just didn't have conversations like that with my patients, maybe an occasional one, but it's the vast majority now, because it's hit the waves of social media, the literature, there are features on television, there are documentaries available now. People are more aware and very interested in two things. One, like we said earlier, in the treatment of chronic, sometimes refractory, meaning it doesn't respond to treatment or hasn't responded to treatment. Those are our neighbors, our children, our spouses, the people we care for and love. And sometimes, and for many of us, it may be us that we are searching for an option. So if we can just hold tight, I do believe that these will be available in a medicalized setting. But like we said earlier, the Oregon Measure 109 is going to give people access to psychedelics to be able, I guess the best phrase is, for the betterment of well people, personal enrichment and growth. So it's like we're getting the best of both worlds. So I invite you, sit tight, and I hope that the presentation today, the conversation that Rakesh and I have offered as an overview of psychedelics has piqued your interest, that you're super interested, you have lots of questions, and then I invite you, we can certainly answer some of those questions and do a little bit of a deeper dive during live Q&A. So we will see all of you very soon.
Thank you so very much to both Doctors, Jan, and they will be joining us at towards the end of the webinar. We will spend the last 10 to 12 minutes doing live Q&A. They will be with us. But right now, it is my great pleasure to introduce Kathryn Walker. And Katie, as she is known, is the founder of Revitalist Centers, and they are one of the largest publicly listed ketamine-focused clinics and in the United States, and they have locations across 8 states. And Katie's going to share her screen with us right now, and she will also be with us in live Q&A, and all of the slides with all of the references will be available after the presentation. Katie, please.
All right, so that I am honored to follow the Rakeshes or the Jains. Let me move this over here. There we go. All right. So my background is I've been a nurse for over 20 years, and then I have advanced degrees in anesthesia as well as psychiatry, more so with a nursing emphasis. Opened the company in 2018. So I've learned a lot, especially after coming from the hospital setting for over 20 years. So my presentation today is the translation of tradition through psychedelic medicine. And one thing that I've learned by doing this, by having this company and really seeing the different angles of, is what Dr. Rakesh Jain was speaking of, is the term curiosity. Curiosity is a great term to have in your mind, but also we don't understand how curious we need to be because this has never been created. So translational medicine is when you take it from the bench and then we're able to actually translate that bench science medicine into the communities. So this is something that all of us are going to have to kind of empower with, to be curious, to be open, to hear our clients when they're trying to seek some type of relief. I think Saundra made a great point when she mentioned on how, really focusing on personal enrichment growth, because that's the way that society needs to start translating itself. Is we go from illness to levels of growth and wellness. And that's how we continue to embrace ourselves. That's how we continue to really focus on our clients and hear them when they speak. I've noticed a lot of providers, when their clients actually do mention psychedelic medicine, a lot of times those clients, we always think that it might make their symptoms worse. And instead, the way psychedelics are really being presented today is it takes the brain to a neutral space. And when it takes the brain to a neutral space, then we're actually able to help our clients identify a lot of those symptoms more so. So what I'll be speaking of today, these are the objectives that I have, is to review the psychedelic medicine data and statistics, discuss potential candidates for psychedelic medicine, and then review environmental factors of consideration for healthcare professionals. This is some of the quotes that I want to include because a lot of individuals have told me the science isn't there. And that is something that's completely false. The science is there. And the beautiful thing about it is it's unbiased science that has been going on since the late 1990s, specifically when Yale made the discovery looking at ketamine and how it did reset the brain somewhat. So you can see some of the quotes here. John Hopkins, just in February of this year, said psilocybin treatment for major depression, effective for up to 1 year for most patients. Over to the right, the FDA granted breakthrough therapy designation to MDMA for the treatment of PTSD. Yale researchers discovered healing effects of psychedelic drug. They find that 1 dose of psilocybin results in roughly a 10% increase of neuron size and density in mouse brains. This is all data within the last year. And then Duke University launches its Center for Psychedelic Science with the aims to advance psychedelic research. So this is real. This is something that we can't avoid. We can't isolate ourselves. We can't tell ourselves that it's made up or it's dangerous. I think Dr. Rakesh had a very good point. You should always consider the risks and the benefits. And the beautiful thing that we're seeing with psychedelics right now is the benefits greatly outweigh the risks. Some of those risks that we do want to mention that are very theoretical, but they should be considered, are serotonin syndrome. So if you're looking at the serotonin receptors, with psilocybin especially, that's one of the receptors that's more common. But with serotonin syndrome, that's just in theory of. But that is something that should always be considered, as well as a glutaminergic storm should always be considered with individuals as well. But again, those are just theory-based aspects of, and this is a completely different world that we're dealing with right now. So Dr. Rakesh had this slide actually in his presentation. So I included this slide in mine as well. But what this shows is neurocircuitry. So when we're looking at psychiatry, we look at chemical imbalances. We question, is it dopamine? Is it too much? Is it too little? Is it serotonin? Is it norepinephrine? How is all of this affecting the way that our brain works? And that's what we've been medicating our individuals and our clients for so long now. But what we're seeing with psychedelics is psychedelics are pro-circuitry. So when you do have a brain that has inflammation, that's duplicating what it knows with depression or anxiety or PTSD, they're showing that there is damage to those receptors in your brain, to your neurotransmitters, to all the brain aspects, to actually decrease the communication skill sets of the brain. So if you look, there's actually a beautiful PET scan with ketamine. I should include it in the slide. But with ketamine specifically, after 1 infusion, it actually shows that the dendrites are actually healthier, which is increasing the communication in their brains, which shows so much promise. So you can see over here on the left, this is just an example of the circuitry in our brain with the communication aspects. And then you can see over here on the right, this is the neurogenesis piece. So a lot of these terminologies that we're hearing now in the field of psychedelic medicine. They are completely different than what we know. They're completely different from my anesthesia training. They're completely different from the psychiatry training. And these are some of the concepts here that I wanted to include, because this is kind of the angle as to how the medications and psychedelics are really changing the way that we view the brain. So when Dr. Rakesh mentioned, be curious, yes, be curious. Every time you tell yourself no, that this is going to be a contraindication for this patient, I would highly recommend that you look up the data and the science first, because it's completely different than the way that we've all been traditionally taught. So some of these terms here that are highlighted, the default mode network. Default mode network is something that's becoming very, very popular, especially when you're looking at psychedelics and the way that they're treating addiction. So with the default mode network, it's a positive reward center or it's a negative reward center. And one way that I like to connect to individuals when I'm trying to explain this to them to get them on really a baseline is with the default mode network, everyone believes in muscle memory, right? Across the globe, we all believe in muscle memory. But for some reason, we've always put the muscle memory terminology into only physical memory. We have never really put it into behavioral memory. So one thing that the psychedelics help with is they kind of take the brain into a neutral space, and then they allow the default mode network to kind of reset itself. And this is when the therapy piece is so important, because if you're able to reset your typical mode of thinking with memory, whether that be physical or behavioral, you really need someone there who's an objective party, who's helping to guide you or to lead you or to process. So we're hearing a lot of individuals coming to the space that they are therapists and or they are life coaches. And my personal opinion is we need both, because there's a lot that we've been exposed to in life that we may need to process, but then also with the life coaching aspects, when we go to a neutral space and it's something, it's almost like going into a foreign country that we've never been into, but it's ourselves, then we do need these individuals who we can trust, who help us to make objective opinions and data and statements to help us to lead the life that we feel like we've all been meant to lead. And it's, it's very exciting. So you can see here the default mode network. I would really highly recommend individuals, all of you, to look up the default mode network. There's a lot of beautiful science there. The functional connectivity, they've actually proven with ketamine, which I'm sure that they've probably proven this with some of the psychedelics as well, as with ketamine, it actually is pro-circuitry. So it actually increases your function of your brain. And they have proven that through some studies. Psychedelic assisted psychotherapy. We personally actually do with ketamine infusions. We have therapists that sit with our clients during the infusion. So they actually do some integrative therapy there, but then they're also there for a base. But we also recommend individuals to do prep therapy as well as integrative therapy. And we recommend it for a minimum period of 6 weeks to a maximum period of 6 months until they can reassess really where they are in this space. The salience network is also a topic that is very exciting that I would highly recommend individuals to look at there as well, because with the salience network, they're proving that rumination is actually a weakness in the structures of the brain. And every time that you can objectively go away from a rumination, you're actually increasing the structure of the brain to where it gives you more chronological data and such to where you can make better decisions, whether that be based on priority or categorization. But they're proving that you can actually do all of these sciences and all these exercises with your brain. So this slide I think is very important. Personally, I think, looking at the central executive network, the default mode network, all these different pieces, it will help you to expand your curiosity, as Dr. Rakesh stated, with those individuals. So candidates right now, based on the current evidence-based data, pretty much what we're focusing on really now is treatment-resistant depression, but then also anxiety, PTSD, palliative care, and especially addiction. Addiction is starting to come into the space. There is a really nice journal in the Journal of Psychiatry that speaks about chronic alcohol abuse and ketamine and how their relapse rates were significantly lower compared to the traditional system that we have now. So these are the individuals that are primarily have the most data out there, but there's also a part of the brain called the lateral habenula. The lateral habenula is a primary portion of the brain to where they feel like it's a processing center. And there have been over 38 neurologic conditions, whether those be from behavioral conditions, pain conditions, and or some type of neurologic aspect, whether that's Alzheimer's or Parkinson's or different pieces there that actually go back to the lateral habenula to where psychedelics are really helping from that aspect as well. This is one thing that I've noticed. So this is one of our clinics to the far left. On the right side is a couple of additional clinics in the United States, but you can see how this landscape really is different than traditional office practices. So you do need a little bit more space. The rooms need to be around 8 to 10 or 5 to 7. Some individuals do like to lay clients on couches. Some like to put with the blindfolds. Some like to have music. We personally have the therapy or the guided coaches during the session. So it's different to everyone, but it really depends on your client as to how best they respond, because you really want them in an environment where they feel vulnerable, but they feel safe and they feel, that it's a place that they can go for healing. So this is something that I would highly recommend individuals to look at with your practices if this is something that you do want to offer with ketamine in the United States. There are a lot of consultants out there that are able to help you with that. And I've probably tried to recreate the wheel pretty often. So if you had questions, I'd be happy to answer them. And this is one quote that I wanted to include in this. So although many of us think of psychedelics as dangerous drugs, it's time for a rethink. They are non-toxic, non-addictive, have very few side effects, and can potentially offer relief for people suffering from a range of psychological difficulties. This is a statement to where, especially with ketamine, the first word that I get out of people most of the time is addiction, that ketamine is addictive. One thing we need to remember in the back of our heads, everything's addictive because we don't know how to turn it off. So it's not necessarily the substance. It's not necessarily the activity. It is the fact of how do we get into the brain? How do we turn that off? How do we reset that? And that's something that psychedelics is allowing us to do, especially, when we're able to work in an environment that's very safe. So in the United States, ketamine clinics do very greatly. Regulatory measures are very broad. Internationally, there are, yes, retreat centers. I'm actually involved with one that we're working on making an international center of excellence because that needs to happen. But that's, yes, you should consider all aspects of the safety, the risks, the benefits. I would primarily tell you that if anyone mentions this in the office to you, please be open-minded. But then also, please consider to encourage them to work on in this sector for at least 6 weeks to 6 months with a therapist or a coach or you, because it cleans off their plate. It makes them very neutral. And then they really it's that time for beautiful integration. So this is me. Here's my my email here. So if you guys would like to email me, please feel free. But thanks for your time.
Katie, thank you so very much. I want to remind folks again that the doctors Jain and Katie and Jazz, who I'm going to introduce in a minute, will be with us to answer questions live when we run through all of the presentations. And one of the things that's very important to us at MHA, in addition to thanking the sponsors of the Regional Policy Council, is to always include what our MHAs around the country are doing in a specific area of interest. In this case, we're going to hear a very brief recorded presentation from Mary Jones, who's the executive director of our MHA of South Central Kansas. And she'll tell you about what they do there that's special with their Esketamine clinic. And then we're going to hear from Jazz Glastra, and she's the director of program operations at the BrainFutures project, which is a project of our MHA of Maryland. So please, let's hear from Mary Jones.
Hi, I'm Mary Jones with the Mental Health Association of South Central Kansas in Wichita. Thank you for inviting me to this session today. I'm very excited to participate with you. I wanted to talk a little bit about the Esketamine clinic that we started in 2019. We were seeing seems to be an increase in treatment-resistant depression. And we have a great team of medical providers here, psychiatrists, nurse practitioners, and other clinical staff who wanted to try something that was innovative and would be supportive to those who were struggling and not finding appropriate treatment otherwise. It took a lot of work to get it going, but we started in 2019 with just a few pilot patients. Unfortunately, with the pandemic, the ketamine clinic slowed down quite a bit, and we weren't taking on as many patients, obviously, as more telehealth became more widespread in the community. We were actually the second clinic to start in Wichita, and now there are 6 fully functioning esketamine clinics in our area. We provide treatment that is by a nasal inhalation, and our providers then sit and monitor our patients for a 2-hour period after the administration of the medication. This allows us to really guide and watch the safety of the medication and also look out for side effects or adverse effects that patients might experience. In our clinic, our experience has been that we have had very rare side effects of the medication and, in fact, very little adverse reaction. What we do have, which is really exciting, are within the first 30 days, people reporting phenomenal success, even for those who really haven't seen much success on other medications. Patients are describing that they are feeling better pretty immediately in the first 30 days of treatment. And for those who have not had much success, that's a really exciting outcome. There's one story we have of a patient whose family member said they were just so glad to have their dad and grandfather back, who hadn't been out of his depressive slump for about 10 years. Those are the reasons why we, as the community's mental health provider here, one of them, want to be sure that we're looking at the most innovative treatments for people and continuing to push our own comfort level in the services that we provide. People who are interested in starting esketamine treatment at our clinic first have a consultation with our psychiatrist, and that person does a complete evaluation to make sure that this is going to be a potential treatment for that person. So after that evaluation, the schedule is set and questions are answered, and we treat people twice a week for the first 30 days. After that, treatment can look a little bit different depending on how people are responding to the esketamine treatment. So for some people, we're going to see longer durations of treatment, and for others, we can see pretty quick, rapid results and not much need for follow-up treatments. However, we have had several people restart treatment and come back for subsequent treatments after that. So after that first 30 days, we really see an individualized approach to what people need ongoing and long-term.
Good afternoon. My name is Jazz. I'm the Director of Program Operations for BrainFutures. We are a national nonprofit organization that is a subsidiary of the Mental Health Association of Maryland. And we know that there is a huge gap between modern brain research and the options that are currently available to patients in the real world. BrainFutures exists to bridge that gap. Over the past couple of years, BrainFutures has been digging a lot into the field of psychedelic-assisted therapy based on the compelling data that you've heard presented by some of my colleagues earlier today. Today, I want to discuss our 3 most recent papers that we've released on psychedelic-assisted therapy over the last year. And then I want to talk a little bit about how can we advance access to these groundbreaking treatments for everyone who could benefit from them. And then finally, I'll talk a little bit about what are some of the policy changes that are already occurring, as well as those that are on the horizon. As I mentioned, we've released 3 papers on psychedelic-assisted therapy. This is what they look like, and I'm going to briefly walk you through each of them. The first one was called Psychedelic Medicine, a review of clinical evidence for a class of rapidly emerging behavioral health interventions. We walk through the clinical evidence for 7 different psychedelic compounds in this paper. It's over 175 pages, so if you've got time on your hands, we definitely encourage you to look through it, but it's also very skimmable. I'll walk through this pretty quickly since some of the other presenters have already covered a lot of this territory. We focus primarily on MDMA, ketamine, and psilocybin. So for MDMA-assisted therapy for PTSD, trials are being sponsored by MAPS, and It is currently in its second phase 3 trial. The first phase 3 trial had pretty astounding results. At the end of the research, 67% of the participants no longer qualified for a PTSD diagnosis. And we anticipate, based on things that MAPS has said, that FDA approval will likely come as soon as the first quarter of 2024. Psilocybin-assisted therapy has also shown great promise for a number of indications, but at the moment, the two companies that are furthest along in the FDA approval process would be Compass Pathways and Usona Institute. Both of them are pursuing indications for major depression, although Compass Pathways is specifically for treatment-resistant depression. And just an example study of psilocybin-assisted therapy, after 12 months after receiving treatment, 58% of the participants in one study were still in remission from their depression, which is a pretty amazing result. Ketamine, you've already heard a lot about, so I won't go too much into it. We're very interested in a lot of promising studies on a range of indications, especially suicidality, the ability to help somebody who is in acute crisis and help them start feeling better nearly immediately in some cases is groundbreaking. And ketamine is currently available both with and without psychedelic-assisted therapy. With and without psychotherapy. We also review in the paper DMT, ibogaine, mescaline, and LSD. Just put a little picture of Albert Hoffman here, who was the person who first synthesized LSD and discovered its psychotropic properties. In our second paper, Expediting Psychedelic-Assisted Therapy Adoption in Clinical Settings, we have sort of one big key takeaway, which is that psychedelic-assisted therapy must be accessible, affordable, and meet high-quality standards if it is to become a successful treatment option for a range of patients who could benefit from it. We have a lot of recommendations, and kind of core to those is that the field must align around these four things. Some sort of clinical guidelines to set a baseline of care that all providers should aspire to. Training program accreditation. Currently, there are many training programs that exist in psychedelic-assisted therapy, but there is little coordination on curriculum or sort of what are the core elements that must be involved. Provider certification, just like any other medical specialty, there must be some sort of certification in order for patients and insurers and those who might pay for this care to understand, yes, this is a provider I can trust. They've been certified by an independent body. And then finally, the last one is a little bit wonky, but there has to be some sort of reimbursement strategy. What do I mean by that? Well, basically, for those who have insurance, typically you would go to the doctor and they don't bill you directly, they sort of bill your insurance. And so there has to be some way for doctors and other providers to describe the services that they are providing in a way that insurers understand it and are willing to pay for it. This is really an access issue. Our third paper that we just released a couple of weeks ago is called An Expert-Informed Introduction to the Elements of Psychedelic-Assisted Therapy. The thought behind this paper was really that oftentimes the compounds themselves, psilocybin, MDMA, et cetera, are the ones that grab the headlines. But we understand from speaking to a lot of experts that the psychotherapeutic container is absolutely critical to those treatment outcomes that you see on my first couple of slides and that you're seeing in the headlines. So this was our process. We conducted 17 long-form interviews. We reviewed published research, and it had an additional 5 expert reviewers. And the interviews were with people who are really leaders and pioneers in this field. So what did we find? Well, some of this, if you're already familiar with psychedelic-assisted therapy, won't be news to you, but psychedelic-assisted therapy combines a psychedelic medication with intensive, highly skilled therapeutic support. So again, we're really trying to emphasize the importance of the psychotherapy. Second key takeaway, as it is currently practiced now in research settings, this model is costly, it's time-intensive, it's resource-intensive, and so we believe that innovation is greatly needed. I do want to walk you through kind of what are the core elements of psychedelic-assisted therapy that we found from our research and from our conversations. So we kind of use this schematic to organize our thinking. In the purple bubbles are sort of 4 phases of psychedelic-assisted therapy, and beyond those, safety and set and setting are absolutely key, and they underlie every phase of the process. So I'll briefly walk through some of the high points for each element. In screening and assessment, currently in clinical trials, screening criteria are very rigorous and a lot of people are excluded for comorbidities such as bipolar disorder or schizophrenia, or even a family history of psychosis. And so BrainFutures is interested in seeing research that starts to push the boundaries of what is known and really quantify the risk to patients with those comorbidities. Additionally, assessment is important here, getting a baseline for where a patient is at with their symptoms. Preparation is a series of psychotherapy sessions in which the patient and the provider establish trust and rapport. There's a lot of psychoeducation around what that medication session might look like, what it might feel like, what that kind of subjective experiences they could encounter, establishing informed consent, all kinds of things like that. And this is thought to be very important for ensuring that people are going into the medication session really ready to make the most of it. This is also one of the key times when set and setting are established. Set refers to the mindset of the patient going into the medication session, and the setting refers to both the social and physical environment in which that experience takes place. The medication session, of course, is when the psychedelic is administered to the patient. Usually it's self-administered in pill form, and they have their psychedelic experience, whatever that might be for them. Sometimes it's mystical, sometimes it's full of joy, sometimes it's fearful, or all of the above. And typically during this phase, the provider takes a very non-directive approach, meaning that they're primarily there to support and are not actively engaging with the patient. And then finally, integration. This is another series of psychotherapy sessions. And this is also thought to be really, really critical to lasting positive treatment outcomes. This is when a patient can work with their therapist to kind of assign meaning to the experiences they had during the medication session, make changes or plans to make changes in behavior when that makes sense, and they can kind of think through how to navigate their relationships in this sort of new state that they have come to, a new stasis. So that's what the model looks like. Now I really want to turn to how can we make sure that all those who could benefit from this treatment are able to access it? And there's a couple of things I want to highlight here. First is the FDA's expanded access program, which BrainFutures would like to see opened up to more slots. Currently, MAPS has 50 expanded access slots for patients who are not part of their clinical trials. So what is the program? Basically, it's between doctors, patients, the FDA, and drug manufacturers. And it's for patients who have really reached a point in their treatment for a serious or life-threatening disease where they don't have a whole lot of other options. And nothing that's currently out there has worked for them. And so the FDA basically approves a certain number of slots, and I believe they may actually approve each individual patient. And the manufacturer has to also agree. It has to be the recommendation of the patient's doctor. So we would like to see more of those slots opened up, even prior to approval. We think that this will help kind of create additional data that payers will be able to use, payers meaning insurers, private insurers, self-insured employers, government payers. So expanded access can help kind of bolster the real world data showing whether these treatments are effective in the real world. The second key aspect to getting access is how are people going to pay for it? As I mentioned before, this is currently a fairly expensive model. And so we'd like to see payers, both public and private, offer coverage for these treatments. And there is evidence that the treatments will pay for themselves strictly from a monetary perspective within a window of 3 to 5 years. And then finally, even if insurance offers coverage for this, not all providers in mental health often will take insurance. And so we need to, as a field and as a system, think through how can we incentivize providers to accept insurance. So here's what's going on the policy front, just in brief. So there's several states that are doing really innovative work with psychedelics. First, Connecticut, so they are funding expanded access for veterans and first responders. So they are going to be hopefully contributing to expanding expanded access, as I mentioned in the last slide. In Maryland, they're also funding no-cost access for veterans. It's through a somewhat different mechanism that I believe is sort of still evolving. Texas is doing something very exciting. They're actually funding a research study on psilocybin-assisted therapy. And in Oregon, as you may have heard, psilocybin services will be legalized in what is sort of known as the wellness model. So it's not a medical model. It's not going for you get a prescription from your doctor and you go and get these treatments. It's for anyone who wants to seek these services. I also wanted to give a shout out briefly to Reason for Hope, which is a group that we partner with regularly. You can see their website URL there. A couple of things that they are doing to advance policy on psychedelic assisted therapy. They have been big backers of the Right to Try Clarification Act. Right to Try is somewhat similar to expanded access, only the FDA doesn't have to get involved. So essentially, a doctor and a patient will reach out to a drug manufacturer directly. It has to be for an investigational drug that is past its phase 1, which is sort of the baseline safety trial. And if the manufacturer and the doctor and the patient all agree, they should be able to access this medication. Unfortunately, there is some confusion over whether that also applies to Schedule I drugs, which are those that are currently, at least by the DEA, considered to have no known medical use. And so the Right to Try Clarification Act says, yes, DEA, like this right to try also applies to Schedule I substances as long as they have passed that phase 1 trial with the FDA, which both psilocybin and MDMA, of course, have. They are also really pushing for expanding expanded access. Say that 10 times fast. So we really are big supporters of Reason for Hope, and I hope you check them out. I just wanted to say thank you very much for allowing me to speak with everyone. And if you're interested in learning more, I hope you visit our website at brainfutures.org, where you can find all of our papers. Thank you very much.
Thank you so much, Jazz. And thank you to all our presenters. And we've got plenty of time for Q&A. So let me start with some of the questions that have come in from the chat. And Jazz, I thank you because a lot of them were policy questions and you just answered them. So that was extremely helpful. I want to remind everybody the slides will be available to you shortly thereafter, not immediately, but you'll get an email when the presentation is recorded and you can download the recording and the slides, and you will have all of the resources in there that you will be able to click on and be able to access them. Kind of question for the docs, and this is about what does the science say about the risks of psychedelics, both especially the ones that people self-administer and administer at home. And either Saundra or Rakesh, please jump in.
Maybe I can get the ball rolling, and Saundra, if you want to add some words to it. I agree. There are risks. They aren't huge, but for some people, they can be substantial. So if one does have a family history, particularly of a psychotic disorder, so things like schizophrenia or bipolar disorder with psychosis, the use of psychedelics can be quite problematic. If someone is acutely suicidal, use of psychedelics can be quite problematic. And that's why I think, Debbie, my suggestion consistently has been weighing the risks and benefits is ultra important with everything, including psychedelics. Those who are using them on their own, you would really want to make sure you are in a mind frame that is healthy and appropriate. And if you do see signs of trouble, please do stop the use of such medications and turn to, if you will, the traditional sources of help. But I will also have to add this. Many people outside of traditional clinical studies do use psychedelics and do get substantial and profound benefits from it too. So it's just a matter of risks and benefits. Saundra, what would you add to that?
Yeah, no, I think you said it beautifully, Rakesh. I would add this, that what you outlined is why it's so important in a medicalized setting to make sure that there is appropriate screening, appropriate family history, appropriate listing of current and previous medication response. All of that it's just required. It has to happen. Outside of a medicalized setting, so whether that would be recreational or somebody's working with I hate the term an underground clinician, but that's the word we're using. I think it is important because there can be experiences that are difficult. Oftentimes, lay people will refer to that as a bad trip. And I think it's important that we recognize language matters and we talk about it, not that it's a bad trip, because many times what's difficult can be very rewarding in terms of what a person learns through the integration process, the meaning making of the experience. But just imagine doing that alone without a sitter or a facilitator, someone with you, can be a little bit risky. So when I hear people, patients particularly, talking about doing a psychedelic substance alone, I almost always walk them through this conversation, encourage them to find almost like a designated driver. If we're talking about alcohol, you want somebody with you.
Thank you so much, doctors. That was a terrific answer to that question. And I want to throw a question over to Katie Walker, please. Katie, and Jazz can jump in if she has some policy things to say here. You know, there's been a lot of usage of ketamine by EMTs, sometimes by police officers, sometimes when people in crisis. Could you shed a little light on that? And then if Jazz, if you have any policy things you want to add, that would be most welcome.
Yeah, no, absolutely. So dosing wise with ketamine, completely different than dosing with ketamine in the hospital system. So typically from an anesthetic standpoint, you give 2 to 5 milligrams per kilogram. It's an IV push, and you give all these other adjunct medications, which really helps to counteract the severe dissociation that ketamine can cause. So if you're out in the field and you're looking to give ketamine to someone, I would not do an IV push with them unless you're going to intubate them or if they're a burn victim or whatever else. What we do in the setting for mental health, and this is across the board, so whether it's mental health or whether it's pain, you give 0.5 milligram per kilo. That's the starting dose, and most of the evidence-based data states that you start there, but 0.5 milligrams per kilogram over a 40-minute period. So you're giving these individuals less than a milligram typically per minute. So put that in context. That's almost like taking half a Benadryl versus taking the whole bottle of Benadryl. So if you're in, I put on one of the questions here, but there's a clinician administered dissociation scale. It's typically used for PTSD. It's a beautiful scale to utilize when you're using any type of ketamine or psychedelics. And then another piece that I want to add to that is there's 3 different pieces. And this is the terminology that Dr. Rakesh, I keep going back because he had so much good stuff to state, but there's 3 different levels with ketamine and psychedelics. So you've got your dissociative piece, right? So that just puts you in a neutral space per se. You have your hallucinogenic piece, and then you have your psychedelic piece. So your psychedelic, it just changes the mind. The dissociative piece, it puts you in a neutral setting. The hallucinogenic piece is where you start seeing things. This is not what we want. We don't want you to start having hallucinations with ketamine and psychedelics. It's more so much a deeper inner meditative style that you go into. So with ketamine specifically, I can't tell you with the others, with psychedelics, maybe Dr. Jain's can, but with ketamine specifically, it does not turn into an hallucinogenic medication until you're greater than 1 milligram per kilogram. It can then. So that's a different level of. So those are the 3 pieces: psychedelics, dissociatives, and hallucinogenics. They're all 3 of the same family, but they have great differentiations. So I would not recommend utilizing ketamine in a mental health setting in the outpatient community. It needs to be in a controlled environment because you're going to take away all these barriers of this person who feels like they're already being attacked or trying to live/die. So it would be a perfect storm that I would highly recommend you not do.
Jazz, did you have anything you wanted to add on the policy front with respect to how ketamine is administered in the field? We can't hear you, Jazz, I'm afraid. We've lost your audio again. Oh my goodness.
She's having the hardest day today.
She's trying.
Oh my goodness. Well, but whoever put that question in the chat, I really appreciate it because there certainly are policy implications for using using ketamine like that to quickly, as Katie said, the dosages to essentially paralyze people, and it's a restraint. It's a form of chemical restraint. It can have very terrible outcomes. There was just a case in Colorado of a young man where this happened to him in an emergency situation that wasn't an emergency for him until police got involved, and unfortunately the young man died. I mean, so these are the kinds of things, as we look to these usages of particularly ketamine in the field by people who are not trained or people who are using it to restrain people, all of our states do need to pay attention to that. And I'm sorry I didn't get Jazz to answer that question.
Maybe I'll add to that as well.
Please.
So with the ketamine piece too, so when you're giving dosing out in the field, which is typically 2 to 5 milligrams per kilo, which is IV or IM, that dose level greatly increases your heart rate. And it greatly increases your drooling ability, right? So a lot of people, if you're out in the field and you're giving these high dosages, people can laryngospasm or aspirate and all these different pieces. When you're giving ketamine at this low of a level, like I mentioned earlier, you're kind of putting these individuals into a meditative state. Their swallowing capacity doesn't typically change. And then they also don't have all of the drooling. So you don't really have to worry about being on site, ready to put somebody on a ventilator, which is really nice, because I got to tell you, from my background, I was very, very worried about that. But if anything, people actually get dry mouths. So this is something too, when you're looking at legislative aspects. I have heard the word consciousness so many times. And what psychedelics do, what ketamine does, is it doesn't affect the level of consciousness as we know it. It should not cause necessarily a sedative aspect. It shouldn't make people go to sleep. We shouldn't be coupling it with fentanyl and propofol and all these other drugs. We should not be putting people on ventilators. This puts people into it acts as a catalyst to put them into a meditative state that puts their barriers down. It allows their subconscious to come available, and it allows this beautiful place to where they can see really what's causing those core triggers. So with those pieces too, just recognize that with ketamine, that's why I love the IV piece of it so much, is because it is 100% bioavailable. You can always slow it down, and it has such a short half-life. So if someone's having a horrible time, you can slow it down and it's okay. It's something that you can take back because it's so quick. So when legislative individuals say, wait a minute, you're doing an IV drug in an outpatient community, this is one of the safest ways to actually administer it, because you do have so much control. So I would highly recommend that. As Dr. Rakesh said, curiosity, keep your minds open, because my mind keeps getting open more and more. And I had no idea it could open to this capacity. But when they speak about levels of consciousness and sedation and putting this into the operating rooms or into recovery rooms, absolutely not. Because what we're doing is we're putting these people in institutions, when really, as Dr. Saundra stated, this is personal enrichment. This is emotional wellness. This is psychological growth. And if we're able to do this, I would love to see how our violence goes down, how our suicides goes down, how our shootings go down, because we're increasing the emotional intelligence of our entire society. I would highly recommend you all to reach out to MHA if there is something to do legislatively with these people who are trying to push it. I did have them in the state of Tennessee. They did try to close my clinic and put it in pain clinics only. Fortunately, I was able to get to Nashville, and I was able to, argue that piece a little bit, but this is a new bubble. It's a new discipline. We need to train everyone. No one knows what they're doing with this unless they've been in the field and they've started training in it. So my personal opinion, it needs to be comprehensive. We all need to come together, and the all we more know, then we can decrease the loss of life that we have. Sorry.
Thank you.
Beautifully stated, Katie. Beautifully stated.
Thank you.
Jazz, can we hear you now? Say hello to us.
Folks, I don't know if you can hear me or if it's going to last.
Okay.
Can you hear anything?
Tell us
Okay.
policy-wise, real quick.
Yeah. So to be honest, the use of ketamine in sort of like law enforcement and emergency settings, from a policy perspective, that's not something BrainFutures has studied. So I don't feel comfortable adding comments to that. But just wanted to say thanks for what you shared, and Katie for what you shared. I think this is a really important issue and something we may look into.
Thank you so much. I want to thank everybody. Katie, thank you. Dr. Rakesh, Dr. Saundra, Jazz, Mary Jones, who was just joining us by video. What an informative way to begin our conversation. So this is just the beginning. We wanted to offer some basic information. Know that we want to hear from everyone. The webinar will be sent out to everybody that is registered. You'll be able to have all the slides, as I said. We have a slide I believe our technical team is going to put up with a QR code that has a link to a survey. Tell us what you thought about what you heard today. Tell us what else you want to hear about, because, as I said, the beginning of the conversation. And before we sign off, I want to once again thank the sponsors of the Regional Policy Council this year. That's Alkermes, Janssen, Myriad, Neuroquin, Otska, Synovian, Takeda Lundbeck Alliance, and Teva. So we really appreciate that. Go back to that QR code for a minute, please, so that folks can tell us what they thought about it. And we really look forward to hearing from you. And as I said, you will be able to access the recording and get all the slides. It will be emailed to all of the registered participants. And once again, thank you so much to our speakers today. And thank you to our participants for joining us. And we look forward to having you join us for future conversations. Take care, everyone. Bye-bye.
Bye-bye.
Bye, everyone.
Bye-bye. Thank you.